started, could you tell us a little bit about yourself and the ICU units that you manage?
Yeah, so I am the lead exercise physiologist for Baylor St Lukes. I've been here for a little over 10 years. I mainly work with thoracic cardio surgery ICU, but I work on every ICU when the patients require more than one person assistance, or they're very difficult patients that are having a hard time getting up and trying to walk around.
Now, you're the manager there? I mean, you have a team with you, or
Yeah,
how
so
does
I have a team of 10 EPs now. We just hired one more. So it would be 10 by the beginning of next year.
and all those different units? I mean, I noticed y'all have some transplant units and some other very complex ICU units.
Yes, we work with everything from lung, kidney, heart, and liver transplant, and we have to work with all those different types of patients. We work with abdominal surgeries. We work with some neuro patients, medical ICUs, a lot of cardiothoracic ICUs. We work with a little bit of everything.
Great. Well, that's really the patient population I think that's we're really targeting. So, I mean, you've used the old unit, you've used the new unit. Can you kind of give us a little feedback about what you feel the differences are?
Yeah, so the big difference to me is going to be the force plate. The old unit did not have the force plate on it, and we couldn't get an actual number reading on it as we can with this one. With the old one, it was great, especially for patients that we had orthostatic or we knew couldn't get up and walk yet. And it was great to be able to get them on the machine and start getting them some exercises. However, with the new machine, we can take some of the guesswork out of it because it gives us their 1RM and we can focus on that. And it's to me, it's a night and day difference of what you could do with it because now all the research potential that could come through it is going to be, it's not going to be subjective. It's going to be very facts, a very number basis. Like this is the numbers that we have based on the machine. This is what they can do. And we can make a lot of research projects from that that could change the way that we look at mobility within an ICU.
Awesome. So there's also been a lot of improvements from everything pretty much being manual to everything being electric actuator controlled now. How did that affect your job?
It saved my back a little bit more because everything is, like you said, everything is a push of a button. The other one was a little bit harder to control sometimes, especially the range of motion limitator that we had to kind of put the cushion where we needed to. And if we had to move it, you almost had to take the patient's legs completely off of it to be able to move it. With this one, we can actually just go in and get our hands underneath it and move it up and down as we need to.
Great. Yes. So, I mean, you talked a little bit about the research implications that the objective force plates are going to give you. I mean, and there is a specific doctor there that's already planning some research. Can you talk about any of these specific research projects that are in your mind?
Yes, a lot of it is not just to help the patients, but it's also going to be to help the medical staff. Because if you look at nursing and how it's been going in the last couple of years, there have actually been increasing their injury rates substantially more than they had before. And what it has been is patients are getting bigger and we're able to provide better medical care. So now patients that would normally not be able to survive a type of surgery are now surviving. But we then have to look at how do we get them back to a normal life? How do we get them back to be able to have a good quality of life? And that goes with mobility. If they can't move, they're not going to get much better. So the nurses have been having to pull them over and having to try to maneuver them, and the patient may not be able to yet. With this, we can actually go and say, if the patient's 200 pounds and they're only pressing 50 pounds on the force plates per leg, can they actually stand up yet? Answer is probably going to be no. So we can actually go and give that number specifically to the doctors and the nurses and be like, hey, this patient isn't ready to stand up yet. They can only sit at your bed at this point in time. And then we can slide them over to the machine with physical therapy, exercise physiologists, and get them actual therapy on the machine itself. So they know what they can do without having to hurt themselves first. So it's going to be great for the nursing staff and for the medical staff to be able to get that number. As far as for mobility for the patients, again, we normally have to go and say this patient's minimal, mod, or max assist, but it could be subjective based on who is doing the actual therapy itself.
Absolutely.
With this, we take that out of the way. There is no, if they're pressing 200 pounds and they weigh 200 pounds, they don't need much assistance. If they're pressing 50 pounds and they weigh 200 pounds, they're going to be around the max range where they're going to need a lot more assistance to be able to get up. And doctors always love to get their patients up. That's their one thing. They come in, especially after surgery, say, "Is the patient up yet?" Well, now we can go and say, "No, they're not quite up yet. They're going to be doing more therapy because they're only at this specific number. They're not quite at the number that we can get them up and walking yet." And the way that I can see it going is we go in, we do an evaluation, we sit the patient at your bed, see what they can do, make sure that they're not tricking you. And what I mean by that is a lot of patients seem okay when you sit them at your bed. They're like, "Oh, they look strong." And then they go to trying to stand up and they can't stand at all. So now you're having to hold them, make sure that they don't fall or that they can do a little bit more. So once we figure that out, we can put them on the new table and have them do the leg press and see, okay, where is the 1RM? Now we have the 1RM. We need to focus on straight. Okay, so now we're going to go in and say the needle work is in between their 70 to 100% of their 1RM for a couple of repetitions throughout the day to try to get that leg strength. Or we could do it the other way. Oh, okay, they can stand up, but can they walk 4 or 5 steps? Okay, so we get their 1RM and say, okay, let's focus in between 30 to 50 on the 1RM range and focus on that so we can get some of the endurance. And we combine that with walking to try to increase their endurance. So now you have multiple ways that you can use that 1RM. We use 1RM with athletes all the time. There's no difference of why we couldn't use it with patients. The body
Yeah.
doesn't change just because you're sick as far as strength and conditioning go. Uh, and one of the things that I teach a lot of the exercise physiologists here is to use what we call the SOS system, which stands for size, overload, and specificity principle. The size principle is the biggest one, because the size principle means the patient, it may not be that they're not strong enough to get up yet. It may be that they lost the ability to activate those muscles. And the muscle is an all or nothing response. You either activate them or you don't. So if you activate those muscles with the machine, now you're starting to get the body to start recruiting more muscle fibers. This is how we can go from not being able to walk one day and 3 or 4 days later, we can get up and walk. And that's what makes this machine so much better. So we can actually focus on that strength range that we need. Because unfortunately, what happens a lot with the doctors and with nursing staff, they're like, "Oh, they must have gained more muscle." It's like, I wish it was that easy to gain muscle because we all be looking like bodybuilders. Um, and
Right.
that's just not the case. So we use that, and we also go into the overload principle. Okay, so now we know this 1RM range may be 40 pounds today. We work on them, and the next week is 60. Their 1RM is 60 pounds now. Okay, so now we work on that. So then we're progressively overloading the patient. And with specificity, in principle, it goes down to it's like this is the squat, so we can tilt them and get them up and do more squats. So it's a sit to stand. It's a modified one, but as they get stronger, we can push them over to start squatting, to sit to stand, and then be able to walk. And that's what we need to do. We need to focus on what's going to get them out of here. The bike, I love the bike and being able to do that on with patients, but honestly, it's teaching them how to bike better. It works with endurance, but not much strength. With this, you can work on both.